चैट कहाँ है? चैट कहाँ है इसमें? हाँ, चैट कहाँ है इसमें? How will I interact with the students? चैट नहीं है इसमें. Got it, got it, got it. Hello? Hello guys, can you hear me? आ गया आ गया आ गया. बंद करो. Yeah, hi guys. Hi, hello, hello. Hello, it started now. Please join in. Hello. Yeah, hi. So happy I got scared for a minute. Yeah, because how am I supposed to ask you questions? Yeah, so hello, good evening, good evening. So is it okay? What do you want to do? Do you want to combine the subjects or should we go through an integrated approach for the next session? Or should we do subject wise? What do you want to do? Hello, really happy to see you all. Thank you so much for coming, for joining in, even though it's all screwed up and yeah. I thought today I'll take derma because it's very fast. Like within 1 hour, within 1.5 hours, we can finish it off. And what we can do is, tomorrow we can keep an image-based session where I will ask you and you should answer. Like I can show you an example. Okay, should I show you what I was thinking of? Wait. What I would do is, yeah. Can you see this? The images here. Like, can you see this? Let's just go through these images first. Okay? So what I did was I put up images like this and I was asking you, what do you think this is? And we know this is a very important image, and even to now in INI this has come and we are learning it. See? Right? So everybody knows this is crumbled tissue paper appearance. This is tissue paper appearance. And please tell me you're all right. Like you're still studying and you're still like with us. So this is crumbled tissue paper appearance. And this is massive splenohepatomegaly, which is seen actually in Gaucher's disease caused due to, yes, very good, glucose cerebrosidase deficiency. What about this one? Can you see this? I'm going to rub it off before you can see. Can you look at this image? Can you look at this? Like I did this in one of the sessions and I was thinking we can have that. Can you look at this? So many of you are telling me hand, foot, mouth disease, but look at it. Here in the eye, you can see conjunctivitis. Conjunctivitis. Okay? This is your strawberry tongue. Mucosal involvement leading to strawberry tongue. What about this one? This is erythema. Erythema on the palms and soles, right? And there will be adenopathy. What kind? Cervical lymphadenopathy. So there was a mnemonic, right? Cream. We have a mnemonic for Kawasaki disease, which is C for conjunctivitis, R for rash, erythema in the palms and sole, adenopathy, which is usually cervical adenopathy, and mucosal involvement showing you strawberry tongue, right? So yes, this is Kawasaki disease. Kawasaki disease. And I really, really believe that images, you should really not, can you see this on what kind? Can you see this? This is actually your palpable purpura and it is in a kid. So what is this? Yes, very good. This is Hinosh-Scholin purpura and it has a triad. Okay, there is abdominal pain, there is palpable purpura as well. What else is there in it? See, just by looking at the image, I think we can do a lot, some sessions like this where we are just looking at the image and trying to recollect. Because when we recollect together, right, this is an active recall. So you will remember this even more, right? Yes, there is no normal platelet count. Yes, palpable purpura and abdominal pain, and one more thing, IgA vasculitis. Very good. IgA nephritis or vasculitis. This is the triad. All clinical questions come based on this, right? So if you know that image, Hinosh-Scholin purpura, it is actually a vasculitis. What kind? IgA vasculitis. Okay. Plus, can you see these two? What are these? A tall male with gynecomastia. Just by looking at the image, see, tall male with gynecomastia. You can see there are no secondary sexual characters present. What is this? Klinefelter. Very good. This is your 47XXY. It is Klinefelter syndrome, right? Very good. And this is your Turner syndrome, wide space nipple, webbed neck. Then you have wide space nipples. This is 45XO, while this is 47XXY. This is Turner, that is Klinefelter syndrome. So we can do something like this if you allow me. Yes, there are streaky ovaries present, short fourth metacarpal. Yeah, wide bore needles, wide space needles, not wide bore needle. Okay, very nice, Prashant, the way you're remembering it. Yeah. So yeah, bar body is present in your Klinefelter syndrome. Okay. Yeah, very good, very good. Most common cause of, okay. So let's start dermatology now. And once we finish dermatology, yeah, let's, tomorrow we will do images like this. Is that okay? If you allow me, and I don't want you to leave till we finish this session. Okay, just give me 1.5 hours. All right? Okay, very good. Now look at this. This is the skin layer. And you know, we have in your epidermis, firstly, it is divided into 3 main layers. Epidermis, dermis, and hypodermis. In that, you have the 5 layers in the epidermis, which is the thickest layer. That is your spinosum. From bottom, you have the basale, stratum spinosum. You can see how big it is. And then granulosum, lucidum, only present in the palms and soles. And finally, without nucleus, it is your corneum, right? Corneum. So these are some images. Which one is this? Can you tell me? Which one is this? Which one is this? This is your racket appearance, right? Okay. So yes, this is Langerhans cells. Now tell me one more cell, which is Langerhans cell only. Where is this cell present? Langerhans. This is a Langerhans cell. What about, this is your Langerhans cell, and the origin was asked. Also remember, these are your Berber granules, right? Where are Langerhans? Very good. It is Langerhans cells is present in caseous necrosis seen in TB, right? So very, very important. With every one thing, you remember the other thing, right? That comes in. This is your melanocytes. Again, these are the cells of the epidermis. They are present in stratum basale. And where was the origin? From neural crest, right? And you should know the derivatives of neural crest because that is an important topic in anatomy. Direct one-liner comes from this, right? Your derivatives of neural crest. Okay? Then this is your Merkel cell. Which is it? Fast adapting or slow adapting? Slow adapting or fast adapting? Let's go to physio. Hello Harshraj. Hello Akhilesh. Hello Empire, Vikas, Sadik, Divya, Ajay, Nisha. Thank you for joining us. Yes, very good. They are type 1 slow adapting receptors. And what was asked in my exam? They asked onion like cells, Pacinian corpuscles, which are type 2 rapid fast adapting, right? So now tell me this, now that you have seen what is the answer, we are studying derma and we will finish very fast, okay? We are studying derma and we will finish very fast. So tell me, what is this? What is the answer for this? Very good. It is your, we just saw the image, right? Yeah, thank you, Ashish sir. Thank you so much. This is your Merkel cell. Again, we saw it was type 1 slow adapting touch receptor. And this had come in my exam, Pacinian corpuscle. Okay. So even Ashish sir teaches in physio, right? So this is seen in Merkel cell. Which one? Type 1 slow adapting. Yeah, I will send the PDF after the session. Now look at this. Look at this question. Again, one topic that is sure to come in your exam. 100% sure. And how many questions are we expecting from that topic? Around 3 to 5. Something which is very, very high yield. It is your vitamins, right? And what do you see here? What is the diagnosis? Tell me the diagnosis. Diagnosis, it is pellagra. Do you need any image for this? Remember the image of pellagra? Pellagra looks like, it looks like, yes, the 4 Ds. There is complaints of diarrhea, dermatitis. Relapses in memory is nothing but dementia. And finally, if there is no treatment, there will be death. So 4 Ds of pellagra. Now tell me, with this topic itself, let's solve 4 more questions. Okay. So now tell me, what is the derivative that gives you what? Yeah, it is due to niacin. Okay, it is due to niacin deficiency. Now niacin is brought by which one? Which one? Which gives origin to niacin? What gives origin to niacin? Very good. It is tryptophan. Now tell me 2 diseases associated with pellagra-like symptoms. Tryptophan. And what does it give you? Does it give you only niacin? Does it give you only niacin? It gives you melatonin. It gives you serotonin. And finally, niacin, right? Melatonin, serotonin, niacin. Say it with me. Melatonin, serotonin, and niacin, right? Very good, very good. So, tell me 2 diseases associated with pellagra-like symptoms. 2 diseases associated with pellagra. Very good. It is deficiency of tryptophan, that is known as Hartnupp's disease. Okay. So Hartnupp's disease also has pellagra-like symptoms. Why? Because deficiency of tryptophan, so niacin will not be made. Again, it will lead to pellagra-like symptoms. Another one, yes, very good. It is, the second one is carcinoid tumor. Carcinoid tumor. Okay, the second one is carcinoid tumor. This is due to increased levels of 5-HT, which is nothing but your serotonin. So if your tryptophan is so involved in making your serotonin, it ultimately is not enough to make B3 or your melatonin, right? So that's why they have pellagra-like symptoms. Very good, very good, very good. So these are, see, can you see from this itself how many questions we have done? The 4 Ds, the diagnosis, which is pellagra. Then you have your tryptophan, which gives you 3. Which ones? Melatonin, serotonin, and niacin. Then Hartnupp's disease, where you have amino aciduria. Okay. And they have pellagra-like symptoms. Carcinoid tumor. And these are all PYQs. They have been asked. What about beriberi? Beriberi, again, you have 2 types. Wet beriberi and dry beriberi. They are caused due to vitamin B1. Even Wernicke's encephalopathy, you know, it is vitamin B1. Right? So, yes. Okay. So, I'm very glad that you're able to, like, just with one question, you can see how many more questions we can solve. Adil ko daru chahiye? Okay, now look at this and tell me the answer for this. Which of the following is not the diagnosis for the image given below? Pellagra mein, it is niacin. Vitamin B3 is deficient in pellagra. Okay, vitamin B3 is deficient in pellagra. Now tell me about this. Very good. Your Wickham's try. And now what topic are we talking about? We are talking about papillosquamous diseases. Can you tell me what are your papillosquamous diseases? You have lichen planus, you have psoriasis, and and tell me one more. Okay, so these are your papillosquamous diseases. And here the answer is yes, very good, Munro's microabscess, because the rest three, yes, they are seen in lichen planus. This is nothing but your reticular lacy pattern, okay, on your hand. And can you see, can you appreciate one thing about here? Can you appreciate one thing? How do you differentiate between the lesions of psoriasis and your lichen planus? How do we do that? I'll tell you today. This is seen in psoriasis while the other things are seen in lichen planus. Okay, and let's do some images related to that. Okay, this is nothing but your Munro's microabscess. Can you see there is a collection of cells? That collection of cells is nothing but neutrophil. Okay, it is a microabscess with a connection of cells on the stratum corneum, right? Yes, very good. Now let's do this image. Can you see what is this? The biggest association of lichen planus is with dental amalgam. Okay, dental amalgam. So these are images that come as clinical questions in your exam. Okay, so dental amalgam, right? Yeah, very good. Dental amalgam. Then look, there are 4 P's of lichen planus. What are they? They're purple in color. What kind of lesion is this? Is this a patch or a plaque? Is this a patch or a plaque? So let's do, since we have enough time, let's do that also. Tell me the basic of derma. Is this a patch or plaque? How do you know what is plaque? So I'll tell you today. I will pass. Thank you, Paras. Yeah. Yeah. So this is a, yeah, very good. This is a plaque. What is a plaque? It is a lesion that is more than 1 centimeter, but it is raised. Okay, 1 centimeter raised lesion. So your pimple, you know your pimple is a raised lesion. It comes out on your skin. What about a patch? A patch is like a birthmark. आपने देखा है आपका birthmark? Is it raised? No. It is just there on the skin. It is kind of pigmented. But so this is more than 1 centimeter, but not raised. Okay? It is flat. Yes, very good, very good. So this is your plaque. It is purple. It itches a lot. That's why it is pruritic. And then finally you have, yes. Very good, Logan. Very good. Yes. Thank you, Paras. Thank you. हाँ वही कर लो, chanting king and PYQ queen. Should we marry each other? Yeah. Polygonal. What else? Yeah. So basically purple, polygonal, papules and plaques. Okay, papules again, they are less than 1 centimeter and they are raised lesions, right? So these are your plaques. These are your, can you see? And can you see that light is reflected on it? So they are shiny in nature, plus they are less than 1 centimeter. So these are your papules, right? These are your papules. No. Thank you so much. Okay, yeah. Now, what is this? What is this? Can you see new lesions are formed on when I'm itching? I'm causing trauma to my skin. So, new lesions are formed on the site of trauma. That is known as, yes, very good. That is known as Koebner's phenomena. Okay, that is known as Koebner's phenomena. And this is seen in only 3 diseases. Can you tell me the 3 diseases? Because that was your June 22 PYQ. This Koebner's phenomena, where you on the lines of trauma, new lesions are formed, that is seen in only 3 diseases. Which ones? Lichen, psoriasis, lichen planus and vitiligo. Okay, very good. Psoriasis, lichen planus and vitiligo. It was an except question asked in June 2022. Okay, so very good, very good. What about this one? Can you see the lacy reticular pattern? Lacy reticular pattern. So this is nothing but your oral lichen planus. Okay, oral lichen planus. And what is this? Again, see, the lesions are purple. Okay, purple. So they are became stray. All right, became stray. Now look at this in the nails. Can you see what shape is this? Purple, polygonal, papules and plaques. Okay, very good. Very good, very good. This is your pterygium. Pterygium. And it is the most characteristic nail finding in your lichen planus. Okay, very good. This is your pterygium. One more pterygium is seen in your eye. That is an image-based question which comes in optha, right? Very good, very good. What about this one? This one, can you see there is no presence of nail? I cannot see nail anywhere. So A, no nichia. Okay, anonychia, absence of nail. Again, these are things, changes that happen in lichen planus, right? So this is your pup tent sign. Can you see it's like a pup? Can you see two people sitting in the tent? Okay. So this is your pup tent sign. क्या? क्लास चल रही है ना? हाँ, तो you saw? Yeah, this is your pup tent sign. Can you see two people sitting inside the pup tent? And yes, this is seen in, yeah, this is seen in lichen planus again. And this is your sawtooth acanthosis. I don't want you to remember the image. It looks like sawtooth, okay? It is seen again in lichen planus. All right, can you switch off the fan beam? Sawtooth acanthosis, right? Sawtooth acanthosis. It is seen in lichen planus, all right? It is seen in lichen planus. Now, what are the images? Again, look at this. On histopath, fan off kar do. On histopath, you can see sawtooth acanthosis, pup tent sign. Let's just revise. Anonychia. What is the most characteristic finding? It is pterygium. All right. Then there's Wickham's tray, oral lichen planus with what kind of pattern? Lacy reticular pattern. All right. And this is your Cobnus phenomena. Remember which three diseases? Psoriasis, vitiligo, lichen planus. And this is your papules, less than 1 centimeter, raised lesions, right? Plaques, again, raised lesions, but now more than 1 centimeter. And patch is not raised, all right? Dental amalgam. Now look at this question again. You saw Wickham's tray, you saw sawtooth acanthosis, and you saw the shiny plaques and papules, right? So, and we saw the image of Munro's microabscess too. Okay? Yeah. Thank you so much, Nescafe Milk. Your names are so beautiful. So yeah, now look at this next question. Look at this next question. Putriosis abscess. Very good. Mycosis fungoides. That question comes, Alia. Very good. Okay. Now look at this. What is the answer for this? What is the answer for this? Yeah, so this is a 27-year-old currently on the treatment of isotretinoin. She's planning to get pregnant. So first tell me, what class of drug is this? What class of drug is this? What class of drug is this? So you can get this drug without prescription. Is that possible? No, that's not possible. So it is a class X drug because it is actually teratogenic for in pregnancy. That's why if a female comes to you, she has been taking treatment for her acne. And what kind of acne? So we have to learn first how many grades of acne are there. We have to learn what is this medication, okay? And we have to learn what kind of class of medication is this. So yes, this is a class X. It is teratogenic. It is an absolute contraindication, right? It can harm the baby. Okay, what about your acne? You have 4 grades of acne. And let's revise. What is this one? What is this one? You know this is grade 1 acne. And grade 1 acne has what kind of lesions? What kind of lesions do we have? Yes, 100% question आएगा इससे. देखो, I will not show you anything that is irrelevant, right? क्योंकि मुझे पता है questions, which questions have been repeatedly asked, right? आपकी मैम मतलब बुक लिखती है ना, तो उसका कहीं तो फायदा हो. Okay, so saw so many images. Yes, these are comedones. Comedones. And you can see these are open because since they are open because of the air, they get oxidized, and these are closed comedones. Okay. And what is the treatment for comedone or grade 1 acne? The lesions that are present in grade 1 acne are comedones. Okay. Yes. Very good. Very good. So what is the treatment? It is topical retinoids. Okay. Topical retinoids like adapalene. All right. Topical retinoids. Then again, what are these? This is grade 2 acne, and can you see lesions which are less than 1 centimeter, which are raised? I just told you which lesions are these? Raised lesions. Yes, very good. They are papules. Okay, papules. So what do you take treatment here? You take topical retinoids plus topical antibiotics. Okay, can I just write TRTA? Okay. Yes, thank you so much. Thank you. Yeah, so topical retinoids plus topical antibiotics. All right. Then what about this one? Can you see this is grade 3 acne? Okay, this is grade 3 acne. And what do you do here? Can you see there is pus in between the lesions? Like there is pus. So these are pustular lesions. This is grade 3 acne. They are filled with pus like lesions, pustular lesions. So now here what do? We give topical retinoids plus oral antibiotics. Okay. Topical retinoids plus oral antibiotics for grade 3 acne. All right. Very good. Very good. Now, and the final thing, what will you do here? Benzoyl peroxide is, see, benzoyl peroxide is topical. So topical antibiotics plus topical retinoids you do for grade 2 acne. Now in grade 3 we actually supplement oral antibiotics. Okay. This is your nodulocystic acne. Nodulocystic acne. Okay. And this is grade 3. All right. This is grade, I'm sorry, 4. This is grade 4. Okay. This is grade 4. Very good. Very good. Very good. So did you get it? Now with me, say what kind of lesions are seen in grade 1 acne? Comedones. They are the most common lesions that are seen. What is the treatment? Again, what is the treatment? It is oral, I'm sorry, it is topical retinoids. Then what is the treatment for grade 2 acne? Topical retinoids plus topical antibiotics. Grade 3 acne? Yes, it is topical retinoids plus oral antibiotics. Okay, oral antibiotics. And grade 4 acne, it is oral retinoids. Oral retinoids in the form of isotretinoin. Okay, so isotretinoin is nothing but your oral retinoid. Okay, and this came in my exam. It came in my exam and I made a mistake in this. So I remember it very well. Right? Okay, very good. Okay, now look at this. Look at the answer for this. Again, look at the lesion. Nodulocystic, pustular, papule, and comedones. And you should remember the treatment like that only. Okay. Now look at this. Look at this. Identify the plant given. So usually we do this in FMT, but here I've written this. Why? Because it is the most common plant to cause dermatitis. Okay. Cause dermatitis. All right. So the answer is Parthenium. This is your Parthenium plant and it is the most common plant to cause dermatitis. Okay. It is the most common plant to cause dermatitis. Now look at this one. Of course, dears, this PDF is made for you. How will I not share it with you? Right? Of course, I will share. Who asked that? Rajendra. Don't worry, I'll share it. Yes, it is also known as Congress grass. Very good, very good. Yes. So, tell me the diagnosis first. I want you to tell me the diagnosis. What is the diagnosis? Yes, it is pityriasis. versicolor. So tell me everything you remember about pityriasis versicolor. Firstly, what kind of lesions do you see? What is this? If it is less than 1 centimeter, and I'm telling you, they are not raised lesions, right? So these ones are patches, and less than 1 centimeter, what do you call them? Patches, and what do we have? Patches plus, we have patches here which are more than 1 centimeter, and macules which are less than 1 centimeter. Okay, so these are raised lesions, these are not raised lesions. Plaque and papules are raised lesions. Macule and patch are not raised. Okay, less than 1 centimeter, more than 1 centimeter. What kind of appearance? Yes. What is the most common organism? Is it Malaysia furfur? Yeah, furfur. Is it Malaysia furfur? So remember, it is not Malaysia furfur, it is globosia. Very good. Malaysia globosa. More than furfur. All right? More than furfur. Very good, very good. So these are your lesions. Plus, what appearance is this? On wood lamps, there is yellow fluorescence, and this appearance on KOH mount is spaghetti and meatball appearance. Now KOH mount, where else have we used that? KOH or NaOH, where else have we used that? Can you associate it with me? Do you remember bacterial vaginosis? There is a test in that known as whiff test. We use KOH or NaOH, or KOH, we use it, right? Yes, in bacterial vaginosis, there is a whiff test. You take the discharge, you put it in KOH and NaOH, there will be a fishy odor, okay? Then, KOH is also used somewhere else. Where? AP test. Do you remember this? This is a topic of OB-GYN. It is a qualitative test. You put the blood of the fetus in the solution and it does not change color. It is resistant. You remember this? So with everything, we should try to integrate other subjects and learn, right? You remember this? I hope you remember it. Yes, very good. Very good. So this is your spaghetti and meatball appearance on KOH mount. On wood lamp, what image is this? Can you tell me what image is this? What image is this? What image is this? Tell me about this. So yes, this is your wood lamps. Very good. This is your wood lamps. And once in our exam, the wavelength of wood lamp was asked. Okay, what is the wavelength? Everybody say it with me. It is 360 to 365 nanometer. Okay, and another question that came in June 22, just related to wood lamp. Can you tell me what this is? What this is? This is your, what is the diagnosis? Diagnosis. Yes, very good. This is erythrasma. Caused by what is a causative agent of erythrasma? Erythrasma, and there is coral red fluorescence. Coral red fluorescence. So can you see, this is an indirect question, but easy, very easy. Seen on, again, wood lamp examination. Okay, seen on wood lamp examination. Very good, very good. So yeah, it is caused by minicetism, right? Okay, very good. Now look at this. Tell me this. Firstly, look at the lesions. How are they looking? Is it purple in color? Because purple, as far as we remember, purple, plain, pruritic, polygonal, that is lichen planus. But here, can you see the lesions are kind of reddish? They are reddish and they are silvery. Reddish and silvery. Right? So this is psoriasis. But psoriasis is what? It is associated here with arthritis. So can you tell me one medication that is the drug of choice in arthritis that we can use here also? Because again, these are inflammatory diseases, right? So you can give the same medication here. So what can be the medication, the drug of choice for this condition? Very good, very good. It is methotrexate. It is methotrexate. Now with methotrexate, can you tell me where else do we use methotrexate? Where else do we use methotrexate? आशीष सर की चांदी कैसे होगी? Yeah, we can use it in rheumatoid arthritis. Yes, very good. Who said that? Hema, very good. We use it in ectopic pregnancy. It is a drug of choice in ectopic pregnancy. RA, ectopic pregnancy. What else? Choriocarcinoma, right? And your methotrexate is nothing but DMARD. What other like medications can you remember? What other DMARD do you know? You know, we just spoke about it in our PSM session. Chloroquine is also a DMARD. So chloroquine is also used in rheumatoid arthritis. What question comes from chloroquine? We discussed it that time. What question comes from chloroquine? Yes, it is bullseye maculopathy, and that in PSM session I told you it was a drug of choice in pregnancy for malaria. It was a drug of choice for ovale and vivax. Okay, revise again. It is the drug of choice for chloroquine for pregnancy, malaria pregnancy. It is the drug of choice in ovale and vivax malaria, right? And for malaria and falciparum, what do we have? We have ACT, right? We made that table. Very good, very good. So look at the two lesions and never forget the lesions, okay? If you're able to identify the lesion, it's very easy. Now look at this. These are more silvery, more red, okay? What about these ones? We saw this was Wickham's striae. It is more purple in color, more purple, okay? So always, whenever you see any lesions, identify which ones it is, right? Very good, Alia, very good. Penicillamine, azithromycin, these are all your DMARDs, right? Very good. Bullseye maculopathy. Now what is this? Can you see? This is seen in psoriasis. There is pinpoint bleeding. What will I do? As the patient, since the lesions are pruritic, it will start itching. Okay? Pruritus is nothing but a fancy word for itching. So it will start itching the lesions, and then what will happen? There will be pinpoint bleeding. What is that? That is known as Auspitz sign, right? Auspitz sign. That is known as Auspitz sign seen in psoriasis. Is it even important to take this session? You guys are all answering. And can you see? Now let's do images of psoriasis. Okay. So sometimes I feel very like with you people, because you know it. So then I'll be like, why am I even taking this session? Okay, so yeah, this is the most common change in your psoriasis. Okay, most common change in psoriasis, it is pitting. What is the most common change in psoriasis? It is pitting. Again, once again, say it with me. What is the most common change in psoriasis? Pitting. But what is the most pathognomic change in psoriasis? Can you tell me that also? Can you tell me that also? Most common, but pathognomic, yeah, specific or pathognomic. What is that change? Very good. You have subungual hyperkeratosis, but this is the pathognomic change. And this was your NEET PYQ. This was your NEET PYQ. It is an FMG PYQ. NEET 2020. ये 23 होने वाला है. 2022 में. 2022, which I could not attempt. This question had come and I taught it to the class. It was a very disheartening thing for me because documents were missing, admit card didn't come क्योंकि ये India है. So yeah, this is your oil drop sign. So most common change is what is the most common change? What is the most common change? Pits. What is the most pathognomic change? It is oil drop sign. Now oil drop cataract is also seen. Where is oil drop cataract seen? Let's integrate. And this is your subungual hyperkeratosis. What is subungual hyperkeratosis? It is just nothing but hyperkeratosis is increase in the number of cells. So they are just keeping increasing from the bed, right? So that is, and ungual is nothing but nail. So increase in cells in the nail, it is subungual hyperkeratosis. Galactosemia, very good, very good. So subungual hyperkeratosis, pitting is the most common change. This is your oil drop sign. These are your two pustules or abscesses. One is the spongy form pustule of Couch, or it is your, what is this? Monro's microabscess. It is Monro's microabscess. Okay? It is Monro's microabscess. No. It is, there are two abscesses in your psoriasis itself. Just remember the names. I'm not sure if they'll ask you the images, but names are asked in the options. Which ones? Pustule of Couch and Monro's microabscess. Okay? So again, these are the nail changes. Then these are the nail changes. How are the lesions? They are reddish and silvery. Like, what is the treatment if it is mixed with arthritis? It is methotrexate. Okay, very good. Now, tell me about this. So, this was asked in June 2021. Very good, Dr. Logan. Very good. Tell me the answer for this. Yes. So basically, what are we talking about? See, this is actually a question related to urticaria, intake of seafood. What is she having? First, tell me the diagnosis. Every question we approach, we should know what the diagnosis is, right? So tell me the diagnosis. Tell me the diagnosis. Yes, this is an allergic reaction. So allergic reaction, can you tell me? How do we have allergic reaction? What happens? Let's go to, yes, very good. It is a type 1 hypersensitivity. And what happens in type 1 hypersensitivity? What happens in type 1 hypersensitivity? IgE, yes, binds to mast cell. Patho. IgE binds to mast cell. Releasing what? Histamine. Now, from patho, we reach to histamine. The function of histamine is physio. So tell me, what is the function of histamine? What is the function of histamine? It is? Yes, very good. What is the function of histamine? It is vasodilation. Vasodilation, basically it causes vasoconstriction in some parts, vasodilation in some parts, and bronchoconstriction. So you saw all those people who have an allergic reaction, suddenly there is swelling. Why there is swelling? Because vasodilation, blood comes, and then they can't breathe. Why? Because there is bronchoconstriction. So see, with one question, how many things we have done? Now, to block histamine, we can use histamine blockers. And there are 4 receptors of histamine. What we need to worry is H1. H1 is related to allergy and H1 is related to wakefulness. Okay. So now what happens? We are blocking histamine, right? Yeah, very good. We are blocking histamine. So how do we block histamine? By giving the first generation that we give. The first generation, because it can cross the blood-brain barrier, it causes sedation. And what are the drugs in that? These 3 are your first generation antihistaminics. What about fexofenadine, your levocetirizine, your cetirizine? All of them are second generation antihistaminics. So they are not supposed to cause, yeah, very good. They are not supposed to cause any kind of, yes, they are not supposed to cause sedation, right? So this can be used during the exam. What? Second generation. So if you are able to integrate patho, pharma, physio in such questions, see with one question itself, how many other questions you're solving, right? Type 1 hypersensitivity, and then this and this. So yes, very good. Now let's go to the next question. Look at the image and tell me what is the diagnosis. So what can you see? You can see a patchy hair loss. And if I remove the hair and take it like this, what happens? It looks like an exclamatory mark, right? It looks like an, मेरी drawing बहुत बुरी है, I'm so sorry. It looks like a exclamatory mark, right? Yeah, very good. So this is alopecia areata. This is alopecia areata, right? Now look at this. This is your circular patch of loss, and what is the treatment? Intralesional steroids, okay? Known as triamcinolone. Look, intralesional steroids are used somewhere else also. Can you tell me where else we'll use intralesional steroids? Intralesional steroids, where else do we? Very good, we use it in keloid. Now with keloid, what is the difference between keloid versus hypertrophic scar? What is the difference? Please let me know if it is okay if we integrate, or are we going too deep in other subjects? So I'll stop that. Let me know if it is not okay. Okay? Yeah. Air server. Yeah. So keloid, very good. The boundaries are crossed while, yeah, very good. It has come. Yeah, the boundaries have crossed. Yes, yes, yeah. Thank you so much. Thank you so much. The boundaries have crossed, but yes, in hypertrophic, the boundaries are not crossed. It is a raised lesion, but will it regress? Yes, it will regress. But keloid will not regress. Okay? Keloid, and the most common places where we get keloid is earlobe and sternum. Right? Yeah. So this is beyond boundaries, your keloid. It is within the boundaries, your hypertrophic scar. Regression is seen in hypertrophic scar, not in keloid, while the treatment is intralesional steroids, right? Very good. Triamcinolone. Very good, very good. Now look at this. What is this? What is this? Yeah. Yes, so this is your, tumor-like growth is seen, it is mycetoma. What kind of infection is this? It can be either fungal or, or what? Or what? Or bacterial, right? What is the cause of bacteria? It is for fungal, it is mycetoma. What about bacteria? What about bacteria? Bacteria is, yes, very good. Mycetoma for fungal infection. And what about, this is Madura foot. Yes, very good. But there are two causes of it, right? It can be either, yes, it has been asked in your June 22 PYQ also. That's why, like, some PYQs I have not added because this was the same PYQ that was asked in June. Okay, it was asked, you saw, no, this was in 2021 also. It was asked in June also. Okay, so this is what happened, PYQ repeat. Okay, yes, actinomycetoma. Actinomycetes, basically. Right. So there are two causes. And what can you see? There will be discharges. What is the difference between the white and actinomycetoma? Okay. Actinomycetes, basically. So what is the difference between your bacterial and fungal infection? What is the difference? What is the difference? There are white grains seen in bacterial and dark grains seen in fungal. Okay. Dark discharges, very good, very good. Yes, very good. Now, this is nothing but your Madura foot. Now, what about the other two options, right? They are also fungal infections. They are deep fungal infections. What about your superficial fungal infections? Which one are your superficial fungal infections? Can you tell me? Can you tell me? Superficial fungal infections. If you remember, your superficial fungal infections are your tinea, all those tinea related, right? They are your superficial fungal infections. Sporothrix, chromoblastomycosis, as well as Madura foot are all deep fungal infections, right? And what do you see? Yes, very good. You see copper penny bodies. Now, what is the other name of copper penny bodies, which was asked in our exam in June 2022? Medullary sclerotic muriform. Very good, Alia. Very good. The other names of this copper penny bodies is nothing but medullary sclerotic muriform, right? So medullary sclerotic muriform copper penny bodies. And this is your June 22 PYQ. June 22 PYQ. Sclerotic bodies are seen in. And the options were given. Because we are so used to learning it as copper penny body, nobody thought of it as sclerotic bodies. What is the answer now for this? Sclerotic bodies are seen in. What? They are seen in? They are seen in. Look at the question and answer. Sclerotic bodies are seen in. Don't look at the image, right? I'm asking you this question. Sclerotic bodies are seen in. They are seen in Chromoblastomycosis. Okay, they are seen in chromoblastomycosis. Copper penny body, muriform body, medullary bodies or sclerotic bodies, all are the same. Okay, they are these bodies only. They have different names. Okay, very good, very good. What about this? These are verrucaceous lesions. They are rough lesions. They are seen again in chromoblastomycosis. Okay, chromoblastomycosis. These are linear lesions. If you can see, can you see that they make a line? Can you see these lesions make a line? Okay, these lesions now that make a line are seen in what? They are seen in sporotrichosis. Okay, don't remember the growth or anything, just remember that these are linear lesions. Okay, they are linear lesions. Very good, Alia, very good. Yeah, they are dimorphic fungi, right? Okay, very good, very good. So one more thing that I want to ask you, on histopath we see some kind of body in it. On histopath in sporotrichosis we see a body. What kind of body do we see in sporotrichosis? Can you answer that to me? So like I showed you, it follows a linear pattern, right? Very good. We see asteroid bodies. Now with asteroid bodies, can you tell me it is also seen somewhere else? Where else is it seen? Asteroid bodies is seen in another disease also. Let's go back to medicine. Okay, let's go back, let's integrate it with medicine. Where do we see asteroid body? Where else do we see asteroid body? Very good, very good. Who said that? Yes, Alia, Sunil, Pradosh, Harshit, Mohammed, Harshit, Gunjan, Ritz. Very good. This is seen in sarcoidosis. Now remember the features of sarcoidosis. There is bilateral hilar lymphadenopathy. Okay, this is an image-based question also. IBQ. You remember the image of your, whenever I'm talking about something, try to recollect that image, okay? Because images, you should be short about it. You should never search for options. या ये नहीं बोला मैम options दे दो, नहीं देगी मैम options. You should know the image. All right, bilateral hilar lymphadenopathy. What else in sarcoidosis? Non-caseating or naked granuloma. Okay, naked granuloma. This is asked in your patho. Okay, non-caseating or naked granuloma. Yes, raised ACE level. Very good. Prateek said it. Raised. Alia said it. Oh my God, Alia, what's up with you? Raised ACE levels. Very good. ACE levels. Alia is really on fire. Alia is like, they increase the time. I will pass. So, okay. So again, look at the lesions. These are linear. Seen where? Where are they seen? They are seen in sporotrichosis. Very good. What about this one? These are your copper penny bodies or verrucaceous lesions, rough lesions. The other name of copper penny bodies is, they are sclerotic, medullary and muriform, right? Then this is your Madura 4. Two reasons for it, either eumycetoma, which is fungal, or actinomycetoma, which is bacterial. Okay. Now look at this question. Now we are going towards cancers, skin cancers. So look at this. हाँ प्रतीक, I didn't know that. पता नहीं बीच में ऐसा हो रहा है कि chat मतलब suddenly students are coming, they're like, huh, what is she teaching? Then they're going back. Okay, yeah. But join and do it. I'm telling you, I try my best to make this session as useful as possible. So please share the link. Please, like, तुम्हारे साथ है. Yes, very good. This is your basal cell carcinoma. Very good. This is your basal cell carcinoma. With that, tell me, what is the most common skin cancer? What is the most common skin cancer? What is the most common skin cancer? Even after knowing that the exam has been extended 2 months away, 200 people still decided to show up. So, chalo, I'm very glad that you, even though you know there is such a big extension, you're still like, let's study. Okay, so congratulations to all of you. Thank you for keeping the spirit. You motivate me. Seriously, you do motivate me. Like, I cannot believe that even after, you know, you're still coming and you're studying. So FMGs यार बहुत strong है, सच्ची में बहुत strong है. Yeah, I will pass. Yeah, very good, very good. So this is most common is BCC. Second most common is squamous cell carcinoma, and third most common is malignant melanoma. Okay. So why am I telling first most common, second most common, third most common? Because what if BCC was not in the option and they asked you the question? What will happen then? What will happen then? I will send the PDF in integrated learning, right? Yeah, what will happen? You will choose squamous cell carcinoma as the answer, right? You will get the PDF in the integrated learning channel, right? So this is very important. The most common cause of skin cancer is basal cell carcinoma. The second most is squamous cell carcinoma, and the third is malignant melanoma. Thank you, Utsav. Thank you so much. Now look at this. Look at this. Do we need to discuss this? Didn't we discuss it before? So this is why I love the theory part, where I can tell you everything and let's do questions. सबको पता रहते हैं, सबको याद रहते हैं. सादिक, very good. Thank you. आपकी मैसेजेस देखकर मुझे मैं वो भी देती हूँ यार. Yeah. So what is the answer? Yes, very good. It is lichen planus. You can see the lacy reticular pattern. Lacy reticular pattern. And candidiasis, does it look like this? Candidiasis ka to image you remember, oral candidiasis, it will look whitish, okay? And psoriasis, we have seen all the images. Yes, very good, very good. All right. So remember about candidiasis. Again, it is there in vaginitis also, in OB-GYN. So you should remember the pH of candidiasis. It is more common in immunocompromised population, pregnant female. Remember? Yeah, very good. What about this one? Identify the condition. Identify this condition. Identify this condition. Thank you, Khurum. Khurum is such a nice name, na? Jasmine, Ahmed, Franco. I love it when you have your own name here, because it's like we are all talking to each other. We are like, ah, chalo, chalo. Leukoplakia again. I'll show you. There's a question of leukoplakia. Very good, very good. This is condyloma acuminata. Can you see? It is a cauliflower-like lesion. Chalo, usse bhi question solve karte pure. Yes, cauliflower-like lesion. And can you see this image? Can you tell me what is this? What is this? I've kept it here so that you can differentiate between condyloma acuminata, which is due to HPV 611, wart causing lesions, right? What about this one? This is seen in, what about this one? Yes, Goda, there is, message me later, right? I'll let you know. Yes, very good, Nishan. Tell me about this one. Tell me about this one. This is your, yes, this is your condyloma lata. Okay, this is your condyloma lata. All right. Can you see these are more papular lesions. So they are around anus. This is also around anus, but these are more papular but this is more cauliflower-like. Okay. So this is how you differentiate. And condyloma lata is seen in syphilis, secondary syphilis. All right. Syphilis. Now with your, yeah, now look at this. What is the answer for this? HPV 611, it causes warts. What about 1618? That causes cancer, right? 1618 causes cancer. With that, you remember the vaccines. There is Gardasil 9, Cervarix, right? And with syphilis, what kind of lesions are seen? What kind of lesions? What is syphilis caused by? Go to micro from here. Syphilis is caused by, it is caused due to Treponema pallidum. And with just syphilis, tell me, Treponema pallidum, what kind of question comes on that? You remember in micro, we have dark field microscopy. That is an image-based question, right? It is an image-based questions with just Treponema pallidum, right? So always keep going back in your mind. Yes, this is low-grade HPV. They cause warts. while 18 causes cervical cancer. Okay? Yes, very good. Yes, very good. Now look at this. I think you already told me the answer for this. This you can see it is only towards one side, towards one dermatome. Okay, it is towards one dermatome. Okay, one dermatome. And what is this? What is this? Against one dermatome. What do you mean by a dermatome? It has its own nerve, vein, and arterial supply. Okay, that is a dermatome. So against one dermatome, that is vitiligo, which is segmental. And what did we learn about vitiligo? We learned that it causes Koppner's phenomena. Koppner's phenomena is seen in lichen planus, psoriasis, and vitiligo. And what is the other thing? यार मैंने fan off कर दिया. It is very hot. Can I just like मैम बहुत hot हो गई है तो let me just just give me 1 second. One minute. Okay, actually क्या होता है ना स्टूडियो में we have lights, so there's a lot of lights and then suddenly the fan is turned off, so it's and I'm talking, so it's getting very hot. So yeah, what is it? It is segmental vitiligo. We learned about Koppner's phenomena. And what kind of lesion is this? Is it hyperpigmented or hypopigmented? I'm sorry with my hands. I talk with my hands like all of you. I think we are all Indians, so we can talk with our hands. ठीक है? Okay. Sahil, yes, very good. So let's learn all the lesions related to hypopigmentation, right? What is this? What is this now? Let's learn all the hypopigmentary, what do you say, diseases. What is this? What is this now? Very good. What is a defect? What is the defect in albinism? What is the defect? That is more important for me. Okay, knowing that is more important for me. What is the defect? What is the defect? The defect in albinism is tyrosinase. Yes, very good. It is a defect of tyrosinase. Okay, this is albinism. Now with tyrosinase, can you tell me tyrosin? It gives you what? Tyrosin. What does it give you? It gives you. Yes, Pratik. Very good. Shingle is again. It is a complication from varicella. Happens later in life, and it is a dermatomal effect. It is seen only on one side along that dermatome, right? Very good, Pratik. Yeah, the baby is cute. Ma'am is even cuter. Yeah, थोड़ा अपने मुंह से तारीफ कर लेती हूँ, ठीक है? Yeah, so very good. It is melanin, T3, T4, and your catecholamines like dopamine, noradrenaline, right? Yeah, very good. Catecholamines, right? So if there is no tyrosinase, can you get melanin? No. And because there is absence of melanin, but the melanocytes are normal. Okay, melanocytes are normal. This question was asked in NEET. Okay, so now you know. Okay, so tyrosinase, what does it give you? It gives you melanin, it gives you your T3, T4 and catecholamine. If tyrosin is not there, you will not have melanin, but melanocytes are normal in this condition. All right, very good. Look at this now. What is this? Again, this is a defect of neural crest. What is this? Can you see the furlock? Right? So tell me about this one. Yes, this is your hypopigmentary disorder. It is piebaldism. Okay, it is piebaldism. What about this one? This one I don't want you to remember that much. This is nevus depigmentosis. Okay, this usually they don't ask in the exam. It is just nevus depigmentosis. All right, just a hypopigmentary lesion, right? What about this one? You know what this is? This is your vitiligo. Okay, again, hypopigmentary lesion, vitiligo. What about this one? You remember I just told you Koppner's phenomena is seen in 3 diseases. Okay, it is seen in 3 diseases. Now, tell me the answer of this. This was asked in June 2022. So you have seen the pattern. I'm more topic wise than like year wise, right? I've mixed all the PYQs. So I don't get confused. All the PYQs are there, they're just mixed because I really like topics. Okay. Yeah, what is this? Very good. We are talking about hyperpigmentation on skin in a 6-month-old pregnant female. What does she have? She has melasma. So let's go through all the hyperpigmentary lesions. What is this now? This is nothing but your, can you see? This is melasma. Okay, this is melasma. They are lesions on the nose, malar, and mandible, and they are symmetrical. Macules. Again, macules, I told you, they are not raised lesions, right? So this is melasma. This is your melasma. Yeah, this is your melasma. What about this one? Everybody knows this. Everybody knows this. Your lentigens, hyperpigmented lentigens on the lips. What is this? Everybody has to know this. Butterfly, see, this is melasma, butterfly rash or malar rash. We know it is seen in another condition. Medicine, batao mujhe. Chalo, medicine. That is seen malar rash, or it is seen in a condition called SLE, right? SLE. Very good. This is your, yes, very good. They are hematomatous GI polyps. This is nothing but your Peutz-Jeghers syndrome. Okay, Peutz-Jeghers syndrome. Another thing that has been asked from patho is that this is autosomal dominant. Again, hematomatous GI polyps and lentigens, hyperpigmented lentigens on the face. What about this one? Can you see hypertrichosis? Hypertrichosis. What do you mean by hypertrichosis? There is presence of hair where there is a hyperpigmentary lesion. So what is this now? What is this? Thoda, there is a difference in the chat, right? Yeah, everybody is replying. I'm getting, yeah, this is now your Becker's nevus. Okay, this is now your Becker's nevus. It is hyperpigmented, plus there will be hair present on it. What about this one? What about this one? Look at the ass. Look at that ass. Okay, this is this is not your nevus of Ota. Mongolian spots. Very good. This is your Mongolian spots. And finally, what do you have here? What is this? Unilateral, involving the trigeminal nerve. Which part of the trigeminal nerve? First and second divisions, right? What is this? Now this is your nevus of Ota. Okay, this is your nevus of Ota. Look at the lesions once again. Nevus of Ota, Mongolian spot, Becker's nevus, your Peutz-Jeghers syndrome, melasma, vitiligo. You have your nevus depigmentosis. You don't need to remember that. This one you need to. It is piebaldism, albinism. Okay? Piebaldism and albinism. Is the speed okay? Is the speed okay? Just let me know and answer this now. Very good. Very good. The speed is fine. Now please answer this for me. Answer this for me. Yes, yes, very good, Ritz, very good. Yeah, tell me. Yeah, okay, very good. So many A's and B's. Firstly, I want you to diagnose it. Diagnosis. You remember in derma, the infection is related to what? It is related to micro. So infection, we are talking about a bacterial infection because the options are related to bacteria, right? And there are two kinds of bacteria you have. One is you have the cocci one and you have the bacilli. Okay? And as far as I remember, bacilli, we don't have infections related to that, right? So please tell me, what is the diagnosis here? Look at the lesions. Can you see this is more than 1 centimeter? And what kind of lesion is this? What happens when you have a vesicular lesion? Have you seen, if you pop out the vesicle, doesn't it look exactly like this? Doesn't it look exactly like this? So if you pop a vesicle which is seen in varicella, so less than 1 centimeter lesion with fluid in it is known as vesicle, and more than 1 centimeter, it is bullae, right? It is bullae. Yeah, very good, Alia, right? So now look at this. What kind of lesion is this? These are bullae, but they are ruptured bullae. So can you tell me, where do you see such lesion? Where do you see such lesion? Can you tell me? Tell me one place where you can find such lesion. Where can you see? Can you tell me again? Very good, Shagufa. Very good. It is seen in impetigo. Now, impetigo, the causes, you have non-bullous impetigo or bullous impetigo. The most common is non-bullous impetigo. And you remember, with impetigo, there is a very good image that comes in your mind. A child with impetigo who has honey-crusted lesions. Remember? Right? So, question kaise pucha? It is twisted. But can't you answer it just by looking at the lesions? At least now, I think, yeah, very good. Impetigo, it is caused either due to staph or strep. Okay, it is caused due to staph or strep, and both staph aureus and streptococcus are cocci. So take out the bacilli, and you know they are both positive. Both of them are gram positive, so the answer here is gram positive cocci. Okay, everybody with me? Did you understand the question? Did you understand the question? This lesion is nothing but non-bullous impetigo, right? And they have asked you what is the causative agent. So the causative agent is either staph or strep. Both of them are gram-positive cocci. Okay, they've twisted it, but it is an easy question. If you know thoda theory samajh jaoge, it is very easy. Okay, very good, very good. Now let's go to this. Look at this. I told you non-bullous or bullous impetigo is caused only by staph aureus. Okay, non-bullous is caused by staph and strep, right? That's what I told you. And this is your which image? This is the image of golden brown honey colored crusted, right? It is a PYQ. It is a PYQ, right? They see, I did not make the question. It is a PYQ and it came in the exam. So it's not my fault if it is lame. It is NB ko gali do. ठीक है? Now look at this. None of the questions here are made by me. Okay, I will not do that. I told you this was a PYQ session, right? Okay, this is your honey crusted. This is your non-bullous. This is your bullous impetigo, right? And what will you have? You will have bullae. Okay, you will have bullae, right? Now look at this question. A patient receives a kidney from his mother. What is such graft known as? Again, simple question. We have all done this question. So let's not waste a lot of time on it. Isograft is seen in twins. Xenograft is seen in animals. Like a graft taken from animals into human is known as xenograft, or other species. You can call it other species also. Auto is from self, while the same species is known as allograft. Okay, so mother is same species. If it was twin, you would have put it as isograft, right? Very good, very good. Thank you so much. Yeah. Now look at this. I see again, you can see the repetition of questions. I just explained the topics to you because I am 100% sure questions will come from that. Okay, so papillosquamous disorder, there will be questions related to psoriasis or lichen planus. Every session, one question was there. Even last session in June, they asked the same questions. Okay, so these topics very, very important, right? Very good. This is your Koppner's phenomena. What about this one? What about this one? Again, not much discussion. What is this? What is this? Yes, very good. This is your subungual hyperkeratosis. This is not sublingual. This is subungual. Okay, I'll just correct it. Subungual hyperkeratosis. Keratosis, right? No, Pratik, definitely. Like, there are some questions which don't even make sense, but NBB has given them. तो और हम क्या कर सकते हैं? चलो, you saw that meme of Paris. Like I posted it on the IL group. Thank you, Gazi. बहुत लेट आए आप आज. Okay, now look at this. Look at this. Look at this. Tell me the answer for this. Tell me the answer for this. Identify the image. What is this? The image is telling you line feces. Okay? Line feces. Alright? Line feces are seen in which kind of leprosy? It is seen in lepromatous leprosy. Now leprosy, again, very, very important for your exam. One is the National Program for Leprosy. The other thing are the medications. What medications will you give in posse and multi? Plus, what are the types of leprosy? So you have how many types of leprosy? You have 5 types of leprosy, and they always start with T and they end with L. Okay? So TT, PT, BB, BL and LL. Right? So tuberculoid, borderline tuberculoid, borderline lepromatous, and lepromatous leprosy, right? These are the 5 types. And there are lesions here that they ask questions on in derma, right? So look at this. Firstly, this is something you can go through. I just want to show you the lesions. Look at this lesion. Can you see that there is central clearing and the periphery is raised? Okay, periphery is raised. And this question was asked in NEET PG as well. Okay, so many people told me, ma'am, a NEET PG question FMG में आते हैं, तो why don't you do NEET? So I'm doing it, right? So this is your annular lesion. Okay, annular lesion with central clearing and raised border, raised periphery, right? Can you see that this periphery is raised? Central clearing and raised periphery. All right. This is known as annular lesion. It is seen in tuberculoid leprosy. Okay? No, Pratik, why will you study first aid book? Don't do that. Don't do that. Okay? And you know it is a granulomatous disease, so it results in anesthesia, alopecia, and hydrosis. Why? Because it destroys nerves. Okay, that's why we have this. What is this? It's your radial palsy, your ulnar palsy, your all those because of. Okay, then Ghazi, आप दिख जाते हो ना? Now look at this. Yes, TT, you have annular lesions. Yes, there is very good Alia. Inverted saucer shape is also there. But उसका image ज़्यादा नहीं आता. What is the scene in BTC? Basically, do you want me to tell you the theory part? The theory part of leprosy? Do you want? So basically, your TT, okay, I told you, no, from T2, it will go to lepromatous, right? Yeah, let me explain it to you. मिल जाएगा कल्याण, मिल जाएगा. So your leprosy depends on your host immunity. Okay, if the immunity is good, then if the immunity is excellent, you will not have leprosy. Like you and me, शायद मुझे है, पर आपकी तो immunity, you don't have leprosy, right? So we have very good immunity. It's excellent. So we will never have an infection. But what if your immunity starts decreasing and now it's only good? So T to B, right? T to L. So the first kind of leprosy that comes is TT, tuberculoid leprosy. It is in its stable form. ठीक है, ये stable है, or it is in good immunity. After that, what happens? If your immunity keep decreasing, it can increase to borderline leprosy, which is actually unstable. It keeps going in different forms, like it will be borderline tuberculoid or borderline, which is the most unstable form, and borderline lepromatous. These keep interchanging with each other. And still, if your immunity goes worse, then you ultimately end up having lepromatous leprosy. So it takes a lot of time for leprosy to be there in your body, right? Did you understand? Did you understand? So first from T to L, TT, BT, PB, BL, LL. right? So it depends really on the immunity. What happens from TT to LL? What happens? Acid fast bacilli increase, your cell mediated immunity decreases, your skin lesions they increase. That's why you have only 1 to 3 skin lesions in tuberculoid, and nerve involvement again increases, right? Got it? Okay, now look at this. The lesion that you have is annular in TT, and the number of skin lesions are around 1 to 3. What about borderline tuberculoid BT? Can you see this is one lesion, and just next to it there is a lesion known as satellite lesion. Like you can see Earth surrounded by the satellite. Earth is bigger. So the bacilli, the acid fast bacilli is trying to get out. And by going out, it leaves another small lesion, right? Because the bacilli, they are increasing. Did you understand, guys? Please give me a yes if you understood everything that I said till now. या आप मुझे छोड़कर चले गए. Just give me a yes if you understood everything till now. Yeah, very good, very good. All right. So BT, what happens from the bigger lesion, the bacteria, the acid fast bacilli is trying to leave, and it leaves a smaller lesion that is known as satellite lesion. Okay. So where is it seen in? It is seen in borderline tuberculoid, which has around 3 to 10 lesions. Again, decrease with immunity, your lesions are increasing, right? Then mid borderline leprosy, what kind of lesions do you have? Can you see they are everywhere and in any shape? So this is known as geographical map-like lesions. Geographical map-like lesions. They are seen in borderline type of leprosy. Okay? And look at this. Can you see these two lesions? Can I call them symmetrical? Can I call both of these symmetrical? Can I call them symmetrical? Can I call these symmetrical? Can I call them symmetrical? Symmetry means they should be the exact replica of each other, but you can see they are, one is on the top, one is on the bottom, but they look almost symmetrical. So if any question mentions almost symmetrical lesions, that is your, which kind of leprosy? BL. Okay, that is your borderline leprosy. All right. Okay, so they should be identical. One side should be equal to another side. Have you seen like a breast? If you would have seen, if you would have done breast examination as doctors for different patients, you would have seen that they don't look alike. One is bigger compared to the other, so they are not symmetrical. That is natural. But मुझे नहीं पता था, and I was doing breast examination for around 200 females, और मैं देख रही हूँ यार लड़के सही बोलते हैं, this is different, this is firm, this is loose, this is hanging, this is that. So yes, all symmetry is like, if you are symmetrical, आप beautiful होते हो. If you are asymmetrical, you are imperfect, which is good, right? Okay, so almost symmetrical lesions, they are seen in borderline leprosy. What about your lepromatous leprosy? Now this is the worst form of leprosy. So what the earliest features that we have is epistaxis and pedal edema. This question was also asked. It was a one-liner, right? Can you reply something? आपने बात ही करना बंद कर दिया मुझसे. Okay, so symmetrical lesions are seen in lepromatous leprosy. Almost symmetrical lesions are seen in borderline lepromatous. Annular lesions are seen in TT. Your satellite lesions is seen in BT. And BB has geographical map-like lesions, right? Very good. So linine feces is a late feature of your lepromatous leprosy where it is symmetrical. You can see you have bacilli, and the bacilli is filling the face. Okay, that's why they look like this. The bacilli has increased in such an amount that it has gone to the face also, right? So they are symmetrical lesions. These are known as linine facies. Other complications in leprosy is your ulnar palsy, your radial nerve palsy. Why? Because there is nerve involvement. Okay? Yeah, very good. So with this, the other thing that we remember is the National Leprosy Eradication Program. And in that, what are the medications that we give for paucibacillary? For 6 months, we give 2 drugs. Which are those 2 drugs? Rifampicin and dapsone. What about multibacillary? We give now 3 drugs. Which are the drugs? dapsone, rifampicin, and clofazimine. So I've written down here, how do you categorize it as paucibacillary and multibacillary? Okay, so yeah, very good. So this is for all, this is for multi, and these two is for pauci. Okay, these two are for pauci. Got it? Yeah. So these are the images of your this thing. Now tell me this answer. Tell me this question, the answer for this question. Tell me the answer for this question. Please give me 10 more minutes, 10-15 max. We are done with derma, okay? So 10-15 minutes max and we are done with derma. The problem is I start integrating, right? So, or I could have finished it in 1 hour. And I hope that is not a problem for you. Yeah, okay. So this is very good. This is drug eruption. Can you see what happens? There is pigmentation in the middle while there is erythema in the periphery. Okay, that is nothing but drug eruption. And how do you know this is drug related? Because the mark will appear on the same site and it heals with it heals with hyperpigmentation. It heals with a mark. Okay, it heals with hyperpigmentation. Very good. Okay, so I've written down here, location is fixed and reoccurs at the same time, heals with hyperpigmentation. Then these are other syndromes. You can go through this. This is your Steven Johnson syndrome, toxic epidermal necrolysis. They are also drug erupted. Okay, these are caused due to drug eruptions. Okay. Okay. Yeah, very good. Now, what is this? What is this? What is this? Can you tell me what is this? Can you tell me what is this? This is your folliculitis. It is an infection of only one hair follicle. Okay. Can you see there is only pus in that one hair follicle, right? So infection of only one hair follicle, that is folliculitis. What about infection of one hair follicle plus erythema around it? What is that known as? 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 Yes, very good. That is a furuncle. So infection of one hair follicle plus erythema around it. Okay. So it is tender, it is painful, right? This is a furuncle. What if there are multiple hair follicles now? Infection of multiple hair follicles. What is that? What is that now? Multiple hair follicles infection. Yes, now that is carbuncle, and this was also a June PYQ. Okay. So it is associated with DM, it is associated with diabetes, and this one. You can see there are multiple hair follicles. It is an infection of multiple hair follicles, while your furuncle and your carbuncle is the infection of one hair follicle. Got it? Very good. Now look at this. Tell me the answer for this now. Since we have done the image, let's solve all the questions. We are almost done with the session. Tell me. What is this? Very good. This is carbuncle. This is carbuncle. What about this one? A patient presented with hypopigmented rash satellite lesion is shown in the image below. Can you see? This is the satellite lesion coming out, right? So what is this? Very good, very good. So you all heard it and you all understood it. So yes, this is your, yes, very good. This is your BT. What about this one? What about this one? This everybody know, this is elephantiasis, right? The image itself is elephantiasis. What about this one? Read the question properly. It's a very good question. A truck driver presents rashes as shown in the image below. He has a history of lesion on the penis, undergoing treatment, presented with rash. What is the diagnosis? So look at this. It is a maculopapular rash. And it has given what? A truck driver. और सबको पता है truck driver ठरकी होते हैं तो इधर उधर मुंह मारते हैं, right? So yes, this is secondary syphilis. This is secondary syphilis. Very good. See, drug eruption will show you an image like this. it will show you an image like this, drug eruption. This was drug eruption, right? Yeah, very good. This is secondary syphilis, maculopapular rash on the hands and soles. Okay, so you remember about truck drivers? They're always alone, so whenever they take a break, yeah, secondary syphilis, very good. And Steven Johnson syndrome, all these three options are due to drug eruption, right? Yeah, very good. Look at this now. Easy, easy. We all can do it. Can you tell me the answer? Just give me 5 more minutes of your time. We will be done. Yeah, what is this? What is the answer for this? Auspitz sign is seen in. You remember the pinpoint bleeding? I showed you the image also. Yes, that is psoriasis vulgaris. Very good, very good. What about this one? Can you see? What is this? There is A, B, C, D, E, right? Right? Can you tell me what is this? See, psoriasis is, what is this now? What is this? What is this? Very good. This is malignant melanoma. What is the ABCDE of that? Okay. E for asymmetry. Like I told you, symmetry you can tell about. Symmetry, one side should be equal to each other. So you can see this is not symmetrical, right? This is not symmetrical, not identical to each other. So asymmetry, B for, you can see the borders. How are the borders? Are they regular? No, they are irregular borders, right? Irregular borders. And can you notice one thing? If you look at this lesion, can you see that here it is light brown, here it is black, it is dark brown here, right? So many different colors. So C for different colors. Sorry. Okay, different colors. Then D for, that has been asked in our exam multiple times. What is D? D is for diameter. And how much should be the diameter? How much should be the diameter? How much should be the diameter? It should be more than 6 mm. Okay? The diameter of this should be more than 6 mm. And E is evolution. Like it will, yeah. Yeah, evolution. Okay? Very good. So this is ABCDE of malignant melanoma. It is the third most common skin cancer, right? Now look at this. Look at this boy. There was an infection that we just learned about that was bacterial, that was on the child, and it was honey crusted. Yeah. Yeah. Yeah, very good. This is post-streptococcal glomerulonephritis. And this is seen in, what is the disease? Yes, impetigo. Impetigo, one of the complication, the most common complication is PSGM. Okay? Look at this. What is this? This is erysipelas. They have very well-defined borders. Okay? Well-defined borders. You can see so nicely. They are very well-defined, right? And it is caused due to, so remember, erysipelas is caused due to streptococcus, while your cellulitis is caused due to streptococcus or staphylococcus, right? And they have very well-defined margin, okay, raised margins. So this is streptococcus. This is streptococcus. Now look at this one. Look at this one. What is this? Yeah, very good, very good. This is your squamous cell. There is a horn present. So, and we did question about malignant melanoma and basal cell carcinoma also, right? Also known as rodent ulcer, basal cell carcinoma. Now look at this. This is a very nice question, very logical also. Okay. So, if active genital warts with history of reoccurrence is present and the husband doesn't have it, then how did the wife get it? How did the wife get it? How did the wife get those lesions if the husband doesn't have it? तो ये wife बहुत चालू थी, हाँ, मुंह मार रही थी इधर उधर, right? After the session, PDF always after the session. So when there are active genital warts, since the husband is so powerful, right? He's innocent, he doesn't even have, वो कहीं और जा भी नहीं रहा, वो बस कमा रहा था अपनी वाइफ के लिए और अपने बच्चों के लिए, और उसके साथ तुमने ये कर दिया. तो what will we do? We will not involve in any sexual activity. Okay, we will not involve in any sexual activity. Okay. Why to make the husband suffer? Why should I give antivirals to the husband? Let him not do only, right? Let the wife get better. Okay. Tell about this again. Very simple question. Very simple question. Very simple question. Tell me about this. Yes, it is sunburn, photosensitivity, freckling, sun exposed area. It is seen in xeroderma pigmentosa. What is the defect? What is the defect? That is a question of patho. Tell me the answer for that. What is the defect? What is the defect? Tell me the answer for that also. Yes, very good. It is photosensitivity, sunburn. It is xeroderma pigmentosa. Molluscum contagiosum, you already know it is caused by pox virus. There is an image-based question which comes every time in exam. Umbilicated papules, right? Yeah, nucleotide excision repair defect. Yes, very good. It is a nucleotide excision repair defect. Repair defect, right? Now look at this. This again, it is showing you the foot, right? So what is this likely? What is the diagnosis here? What is the diagnosis? What is the diagnosis? The diagnosis is hand-foot-mouth disease. And hand-foot-mouth disease is caused due to Coxsackie virus. Which strain of Coxsackie most commonly? A1. Pox virus causes what? It causes pox virus. We just saw it, right? Molluscum contagiosum. Molluscum contagiosum. What about herpes? You have the oral and genital herpes, right? So HSV 1 and 2, right? And HPV, you know, 611 causes what? While 1618 causes, what does it cause? Yes, it causes cancer. Now look at this. The lesions are centripetal. They are faster evolving. So what kind of lesions are these? From one stage to another, very fast they change with fever. And can you see again what kind of lesion is this? If you can see, they look like burst vesicles, right? Vesicles. So it is seen in, very good, it is seen in chickenpox. What kind of appearance? Very good. Who said that? Alia knows everything. I don't know why I'm teaching Alia. Yeah, it is chickenpox, and it is seen in, what appearance you see is dewdrop appearance. Okay, dewdrop on rose petals, right? How are the rashes? It is centripetal and pleomorphic. They have different, like they are different sizes, right? And it is caused due to varicella zoster. Then this one, this is the last image. This is your contact dermatitis. And one question that comes in your contact dermatitis, is what kind of hypersensitivity is it? What kind of hypersensitivity is it? What kind of hypersensitivity? Tell me. What about allergic dermatitis? What kind of hypersensitivity is allergic dermatitis? Very good. Contact is type 4. What about allergic? Okay, very good. So allergic and your contact dermatitis is one and the same. Okay, allergic and contact, they are almost the same, and they are type 4 hypersensitivity. Both contact and allergic dermatitis are type 4 hypersensitivity. Then what is type 1 hypersensitivity? What is type 1 hypersensitivity? Look at this. Atopic dermatitis is type 1 hypersensitivity, and it comes with a triad. Okay, what kind of triad? You have atopic asthma, you have atopic rhinitis, and atopic dermatitis. Okay, so atopic dermatitis type 1. If they ever ask you allergic or contact dermatitis, it is type 4. And what other dermatitis do we have? This is known as the cradle cap, you remember? Cradle cap, right? Cradle cap, greasy nasolabial folds, lesions which are, yeah, this is seborrheic dermatitis. Okay, seborrheic dermatitis. Got it? And we are done. One topic that we have not done in this is pemphigus disorders. Okay, so what is the most common pemphigus disorder? You tell me that also. That is the only topic that we have left in derma, where I haven't like I didn't see much questions of that. But pemphigus vulgaris, you remember? Yes, most common is pemphigus vulgaris, because vulgaris itself means what? It means most common, right? So your vitiligo vulgaris, it is most common. Vitiligo, right? So it is pemphigus disorders. You remember pemphigus vulgaris? What is the defect? There is a defect in desmoglein 1 and 3, right? So seborrheic is this one. All right, seborrheic is this one, and seborrheic is this one. Seborrheic is this one, right? Yeah, desmoglein 1, 3, right? So go through the images, or I will add images of pemphigus also in this. Can you go through them? Can you go through them for me? Okay, go through the PDF. Keep this PDF for the last minute, and एक साथ ऐसे 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 करके देख लेना. I'll add the pemphigus disorder in this. Just go through last minute. That is the only thing we left in derma, right? So go through this, and thank you for joining me even till the end. Like, you guys, 190 people of you, like पता नहीं कहाँ से आपका motivation आ रहा है, पर you have stayed till the end, so thank you for that. And thank you for having me and for letting me teach, because you people make it better. Like, whatever is going on in my mind, when I am with you, that's it. I forget everything. So thank you for that. Thank you for giving me that gift, and keep studying. These 2 months can change your life. Okay, so let's keep studying together, and let's take another session once again. We will keep doing this and being united. Okay, FMG, the best part is do it together. ऐसा नहीं कि दोस्त नहीं है, दुश्मन है, ये सब साथ में. Why? No negative marking, no competition. सब मिलके पास होंगे. I will pass. So let's end this session here. Thank you so much. Okay. बंद कर दो, बंद कर दो. कहाँ हो तुम? Yeah. See, I'm saying